had a distinguished career with notable positions including Registrar at TB Sanatorium, Gotri, Vadodara, KEM Hospital, Mumbai. He also worked as full-time consultant at Muni Seva Ashram Hospital, Goraj, consultant pulmonologist at Sangam Chest Clinic, Vadodara, honorary associate professor at Pramukh Swami Medical College, Karamsad. Sir is founder and consultant pulmonologist at Kailash Hospital, Jetalpur Road, Vadodara, Gujarat since 2004. He is also a visiting consultant pulmonologist in various hospitals and ICUs, including Bhailal Amin General Hospital, Vadodara. Please note that we have a question and answer session at the end, and we request you to keep your audio muted during the session. Without further ado, please join me in welcoming Dr. Manoj Yadav, who will enlighten us to the nuances of chest X-ray interpretation. Over to you, sir.
Thank you, Dr. Tanvi. And I am really thankful to the whole team, your team, who has invited me for this talk. Dr. Jaspreet, Dr. Advita, Dr. Pragna, Dr. Tanvi, Dr. Joel, Dr. Pooja, Dr. Ruchi, and Dr. Sanjeev. So today's topic is chest X-ray interpretation discussion. Let us start with why we need it. So these are some of the old X-rays. These are the analog from the analog machine, not the digital ones. So if you see this X-ray, what do you see? A lot of shadows here and there. But is this a very good X-ray? Can you make out the lesions very clearly? Some of us can, and some of us would not be able to. So in this X-ray, you can just have a diagnosis in your mind about what you are seeing. Routine reading of the X-ray should not take more than a minute to the experienced eye. So in this X-ray, there will be mottlings here and there. And if you see very clearly, very properly, there is a shadow here or a thin line. So this is a pneumomiliary opacities with a left pneumothorax. Can you see here? It is more appreciated here. Now, these are some of the lesions which are easily missed even by an experienced eye. So we need to have a clear understanding of how to go around seeing the X-rays, and there should be a stepwise approach. In this case, again, the same patient with the ICD in situ. So these are X-rays, different X-rays which we see. I will just move over to this topic. So the aims are to lower the basics, the best exam results, appreciate the role the radiology plays, and instill an interest in radiology. The contents which we need to understand is the densities, technique, anatomy, chest X-ray interpretation, common pathologies, and of course, some questions we'll be having. So the two big densities in any X-ray is white, which is bone, and the black, which is air. The others are the dark gray, that is the fat, and the gray, which is soft tissue and water. And if there is anything man-made, it is on the film, and it is radio opaque, then it is bright white. So in this X-ray, we have everything. So here you have the lungs, here you have the breast shadow, the mass, muscle mass and everything, the heart, the liver, and here this is a machine. What is it? It is a pacemaker. And as you can see, the air totally black outside the chest, outside the body is totally black. And here this X-ray is actually overexposed. So you are seeing a more of blackish shadows. The technique is routinely we see that chest X-ray PA is being advised. So what is PA? That P is posterior anterior. So the beam of the X-ray machine is on the posterior and the anterior aspect is on the plate. So the patient is standing like this. So the X-ray beams will go through here, and this is the plate where the X-ray will be taken. Then we have, so this is a typical chest X-ray PA view. The other techniques are the AP, that is anteroposterior, which is usually taken when the patient is in a supine position or in an erect position in some cases. Then there is a lateral. So it is also lateral in the standing. So we get such X-rays. Nowadays, with the advent of CT scan and the cost of CT is going down, we don't require lateral X-rays in most of the cases, we directly order for a CT chest to have a better view of what is going on in the chest. Then there is a lateral decubitus. This X-ray is important. This projection is important in patients, especially in the ICU or cases where we are not able to shift the patient for a CT scan. And where is this important? One is if there is a small pleural effusion which is not visible on a PA or AP view, then a chest X-ray lateral decubitus is important. Here you can see that the fluid has gravitated and it is showing more prominently on the lateral decubitus. Similarly, if there is small pneumothorax, then it will be visible here in a lateral decubitus. Then we can have special techniques like oblique view also. After the projection, type of projection, then the orientation of X-ray is important. In a normal X-ray, the right technique should be where it is very well centered. There should be equal distance between medial end of the clavicle and the midline. This is true only in patients who are having no kyphoscoliosis. So, what is the importance of a rotation? So, if the patient is slightly rotated, suppose in a normal patient, the chest is properly aligned to the plate. However, in other case, if suppose the shoulder or one side of the chest is more near to the plate, even by a few centimeters, like even 1 centimeter, so the patient will be rotated. And what happens is that here, see, as you can see, the clavicle is now over the spinal projections, and this end of the clavicle is away from the midline. This is more towards the midline. So what has happened is this part, the one which is away from the plate, will look more black because now you have more air in between the plate and the chest, and this part will be more like ground glass or the grayish. So I hope you are understanding the importance of a rotation. In our practical experience also, we are seeing that some patients are being misreported as having increased vascularity or increased reticulation if the patient's chest X-ray is rotated. Then comes the penetration. Penetration means the beam, the X-ray beam which has been given. So normally an experienced technician will give an X-ray which is like this or this. However, some patients, like very hefty patients, obese patients, if the same amount of beam radiation is being given as for a normal person, then it may be underexposed. So here you will have more of this soft tissue which is coming as white, and the lungs will be more grayish, as you can see here, more grayish. If, however, the patient is thin and lean, or the beam or the X-ray beam is more powerful, then everything will be washed out, like here. Not washed out, so it will be radio black, not opalescent, right? Now see the X-ray here. As you can see, this X-ray is overexposed. You can see the spine, and here it is all blackish. Now this is a little less exposed, and as you can see, the patient is having shadows all over the chest. Coming to where the lesions are, so we can see that there are lesions here, predominantly here, and the whole of the left side. So let us go and see, understand further about the projection, about the thing. Okay, so this is an X-ray of a patient which is, I would say, underexposed. As you can see that it is more whitish. What is the importance? The importance is this patient's X-ray is of 2009. The another X-ray done even 2 years back, but on a digital machine. And here it is overexposed. And you can see that this patient had undergone heart surgery. These are the staplers, right? These are the wires actually for a cardiac surgery. So if we don't know, and the patient may not be able to give or recall that they have undergone surgery, or sometimes they don't want to say, we may miss this diagnosis because the patient has undergone surgery for a cardiac disease. Possibly there is a valvular heart disease. You can see the conus, pulmonary conus, which is prominent here, this here also. So in the absence of this, if I was given this X-ray, then I would say there is some mass lesion here. But with this X-ray, I would say that this is nothing, this is just a part of the cardiac problem. Then the importance of inspiratory and expiratory films. So here, as you can see, this is a very well good inspiratory film where the apices are full and the diaphragm is going very well convex. In an expiratory film, the diaphragm will be bulging up and there is an angle between the heart and the diaphragm. This side we sometimes may not be able to see, right? And here also you can see. So here on the right, in a good inspiratory film, the lever side, the right side would be up, and in the expiratory film, most of the times, both the diaphragm would be on the same side. The importance of this lies that in an expiratory film, you will have more congested lungs on the bases, and they can falsely be misdiagnosed in such cases. So ideally, there should always be a inspiratory film, not an expiratory film. The patient should take a deep breath, hold the breath, and that time the technician shoot the X-ray. What happens is the patient is asked to take a deep breath and asked to hold the breath, and that time they just leave the breath and the technician shoots. Now coming to the anatomy of X-rays. So broadly, we know that this is the clavicle, both side. Then this is the scapula. This is the vertebra, which is going from up to down. And here are the ribs. This is a MRI image. So this is the heart. And this is the lungs, ribs. Okay. And here on the MRI, you can see that this is a fissure, horizontal fissure. Right? The anatomy, understanding the anatomy. So the lungs, as you all know, on the right side, we have 3 lobes, upper lobe. So on a plain X-ray, the right upper lobe will be the shadow, the blue shaded area. On the lateral X-ray, it will be occupying this area. The middle lobe will be occupying on the right PA, this area, and on the lateral X-ray on this. And the lateral X-ray, right lower lobe will be going right from down to up. Why this is important is, if there is a lesion, suppose here, okay, suppose there is a lesion here, so we may actually misdiagnose it as a right upper lobe lesion. Actually, it may be right lower lobe lesion also, because the right lower lobe is going right up to the posterior aspect towards the apex also. Similarly, coming to the left side. So here we have the left lower lobe, which is again going posteriorly upwards. This is the left upper lobe with the lingula. As you can see, it is more like a slant. So even lesions of the lingula will be seen in the lower zone. I forgot to tell one thing, and that is that when we report X-rays, we have to divide it into 3. So 1, 2. So the lower border of the second rib and the lower border of the fourth rib. In between these two is the middle zone, mid zone. And here it is the upper zone. And anything below it is the lower zone. So on an X-ray, we cannot say with definite that it is upper lobe lesion, lower lobe lesion, or middle lobe lesion. We can say in upper zone, mid zone, and lower zone. And then we have to clinically correlate whether in which lobe it is present. Then we have the layers of the pleura, which are not visible usually on the X-ray, except for the apices. When the pleural thickening is there, then sometimes we will be able to appreciate that. Or pleural thickening in cases of old pleural lesions like empyema, which is healed. Then we have important structure, the heart, in the chest X-ray. The right border of the heart is actually representing the right atrium, edge of the right atrium. The left border is the left ventricle and atrium. The posterior border is the left ventricle, and the anterior border is the right ventricle. So to remember easily, the right ventricle in the right atrium will be the right border and the anterior border, and the left atrium will be forming the left border and the posterior border. You can see here. So here is the right atrium. Here is the right ventricle. Okay, this is the anterior part. This is the right border. Okay, and here we'll have the left ventricle and atrium, and posterior will be left ventricle. So other things are the ascending aorta, the aortic knob, and the descending aorta. Then we have the pulmonary artery, the aortic knob, which is already shown, and this is the AP window, aortopulmonary window. Right? So these are the walls, not important for us. Now coming to the mediastinum. So the normal width of the mediastinum is actually half of the total length of the width of the chest. The hilum is made of pulmonary artery and veins and the bronchi. The left hilum is always higher, and they are both usually identical in size, shape, and density. As you can see, that the left hilum is slightly above the right hilum. Actually, the lower border of the left hilum is at the level of the upper border of the right hilum. And the hilar density would usually be same. Why this is important? So if suppose, and most of the times, if there is a small lesion, suppose here, a dense lesion, slightly dense, then you have to suspect that there is possibly of a lymph node and possibly a malignancy. To detect very early, we can know that there is something going on here. Again, if the hilum is prominent, then it could be because of either mass lesion or because of even enlarged pulmonary arteries, because of pulmonary hypertension. These are the ribs. So we count from back. So this is the first spinous process, the 1, 2, 3, 4, 5, 6, 7 to 10. If we see, if we actually trace it forward, then this will be 1, then this will be 2, then the third one, then the fourth one, right? Okay, so this way we can go all the way down. Now coming to the soft tissue and the bones. So we already talked about in the earlier part, I said that we have to look for other shadows like breast and diaphragm, and bones we already discussed. Lateral X-ray, I think I'll just skip because nowadays we hardly take any lateral X-rays. Coming to the chest X-ray interpretation, we have to know the technical details of type, orientation, rotation, inspiration, expiration, penetration, which we already talked about. Densities, symmetry, lesions, we already talked. Now the heart size is literally the same. We have to measure like this. The heart size should be normal. It is nearly half, but it has to be measured from the most lateral aspect of the right border and the most lateral aspect of the left border. And this two should be equal, or sorry, half of the total length of total width of the chest. Mind you, that this has to be measured only in a patient when the X-ray is in a proper inspiratory film. If we are doing it in an expiratory film, the heart border will look to be more, and we may misdiagnose it as a cardiomegaly, because in such a case, the width of the chest should be less, right? So the size of the heart, size of individual chambers of heart, size of pulmonary vessels, evidence of stents, clips, wires, and walls, which we have to see, and the outline of the aorta and IVC and SVC has to be seen. In the mediastinum, we need to see the width counter and the AP window. The hila, we have to see the size and location. We need to review the apices. So when we see an X-ray, what we need to do is have a quick look from the apices. We have to just see if there is anything behind the heart. We have to go to the CP angle, then see whether there is something missing below the diaphragm. Then we have to train our eyes to see the soft tissues like the breast, surgical emphysema. So how we know the surgical emphysema? That is by air in between the soft tissues. Then we need to see the ribs and clavicles. We may actually find that the clavicle is fractured or the ribs are fractured. Then we have to see the vertebra where there is any fracture or compression, or whether the vertebra is showing a kyphoscoliosis or there is any other problem. So once we see the lesion, we need to identify it properly, localize it, describe it, and then we need to give the differential diagnosis. We should never stop looking that once we see a lesion, we should forget about seeing the other parts of the X-ray. We need to see, like in the first X-ray, as I had showed, there were a lot of nodularities. If we focus on that, we may actually miss the pneumothorax. So never stop looking, carry on with your systemic approach. So you have to see each and every thing, like start from apices, behind the heart, CP angle, below the diaphragm, soft tissue, ribs and clavicle, vertebra, and general lungs. Right? So after having discussed all these things in brief, I'll now come to X-ray interpretation and some diseases. So all of you can just see this lesion, this X-ray, and write it down what it is, and then I'll go ahead. So this is actually consolidation. As you can see, it is in the upper zone, right? And it is going right above to the apex. So most likely this is a consolidation. And here, as you can see, the horizontal fissure is actually bending upwards. So there is loss of air, and that is why the lung volume is decreased of the upper lobe, and the fissure is bending. It is a concavity towards the it is convexed upwards. Then we have a lesion here, right? On this X-ray, we may feel that it may be a right lower lobe or a right middle lobe. But the thing is that this lesion is in continuation with the hard border. So you can't see the hard border. So it is in continuation with the hard border. So it is a right middle lobe. Had there be a border, right hard border seen properly with this lesion, it would have been a lower lobe pneumonia. You can see very well on the left side, left lateral X-ray, that this is the right middle lobe pneumonia. Then you can see that there is a lesion here. So is this a consolidation or is this a pleural effusion? So it could be a consolidation with a pleural effusion. Now, this is a lesion, as you can see, of a patient on 13/4, right? And we are having, it is showing lesions in the right lower lobe, right mid zone and lower zone predominantly. However, the patient's chest X-ray taken just 2 days later shows widespread lesions all over the chest, and they have become more prominent. And a CT scan would show that the whole lung, right from the apices to the base, is involved with consolidation, as you can see here. Okay, so this was a case of vaginal granulomatosis. However, so the CT scan urgently was done, and we could identify, or we can suspect, that this patient has gone from this X-ray findings to this within 2 days. It was a fulminant case, and we successfully brought him out. This is a case of a lady. Now, what you can see, just write it down, and then I will say, just keep in your mind what you are able to see on this X-ray, and then I will go ahead. I'll just take 10 seconds. So, as you can see, there is a huge heart. But before that, you see that whether it is rotated. So no, it is not very well centered. Sometimes here the lesion is quite big. The heart is quite big. So it may not be so significant. But if the heart is not so big, even a small rotation can cause our readings to be erroneous. So you can see our cardiomegaly. You can see that the right hilum is prominent. The left hilum is actually not seen properly because it is overshadowed by the right atrium. Left atrium. And here you're able to see shadows here, right? This is haziness, reticulonodular shadows. So here was the CT scan. On the CT scan, you can see there's some ground glass opacities in the upper lobe cuts. However, the lower lobe cuts are also showing some ground glass opacities and with a huge heart, right? So this was a case of valvular heart disease. Old lady, but never suspected to have a valvular heart disease, and she came with hypersensitivity pneumonitis with a valvular heart disease and cardiomegaly. Now this X-ray. Now we are seeing shadows in the upper zone, mid zone, lower zone, and here again in the mid zone and lower zone. So which lobes are involved? Let us see. So from the CT, you know that now it is in the right upper lobe and right lower lobe and left lower lobe. The right middle lobe is spared. So as you can see, here you are able to see the border of the heart. So although this shadow is here, it is not actually in continuation with the border, and so it is in the right lower lobe and not in the right middle lobe. Now, this is an X-ray I have specifically put to understand the importance of rotation. On this X-ray, you will feel that the patient is actually having a right pleural effusion, left pleural effusion, but actually it is not so. As you can see, a very well rotated film taken shows that actually there is very few lesions on the left lung and the heart is actually normal. There is nothing much wrong in this X-ray. So the importance of rotation. This is a lady whose X-ray was taken. She's an asthmatic, and all of you can just have a look on this for 10 seconds and say what you see. What is the lesion where you suspect, and whether this is an inspiratory or expiratory film. So as you can see, the X-ray is slightly rotated. The clavicles are not in center, or not as per slightly there. This side is slightly away from the midline. The X-ray showing expiratory film rather than inspiratory film. And there is a lesion here, soft tissue lesion. As I said earlier, in an expiratory film, the bases may show a congestion abnormal. But however, this lesion looks to be very homogeneous. And on CT scan, it was shown that this patient was having a right middle lobe consolidation or this shadow, right? And this is actually mucus plugs and fungal infection. Then coming to patients having effusions. On this X-ray, you are able to see effusion. Now, this X-ray is also a bedside and underexposed. You see a lot of white shadows, right? And the same patient's X-ray, other X-ray is showing that the fluid has actually gone. It is not there. But if you see properly, this X-ray is overexposed, so much overexposed that this white lesion, this white shadow, because of the X-ray, because of the fluid, it is totally gone. So when we had a proper X-ray, again, not good quality, it was gone actually. Now here is an X-ray of showing a very well air bronchogram. You can see the shadow of the bronchus or airways within the consolidation. This is called as an air bronchogram. This is a left upper lobe pneumonia. Now, although we feel that this may be a lower lobe pneumonia also extending, but it is not. We know in the first earlier slides we have shown that the left upper lobe may actually be this way. Okay, then we have a left lower lobe consolidation with a cavity, right? Then on CT, we see the consolidation more properly, and this is the air bronchogram which is seen. Now, what is this? Now we have talked about the hyla. So this is in condition of the hilum, and possibly this is a lesion from the hilum, hilar malignancy. The enlarged hyla can be caused because of adenopathies like neoplasia, infection, primary tumors, vascular causes, or sarcoidosis. Now, on this X-ray, you can see multiple shadows, nodules. These are actually typical of metastasis, multiple masses, or metastasis or malignancy. This shadow, this X-ray actually shows a very prominent hilum here also and here also, bilateral. So these bilateral lymph nodes in sarcoidosis, most commonly in sarcoidosis, very rarely in tuberculosis, but mostly unless brother it is sarcoidosis. As you can see here, it is very well appreciated on CT chest. Here you see the right pleural effusion, left pleural effusion, huge effusion. And how do we know whether this shadow is from the pleura? You have to see the angle. So if it is obtuse angle, it is from the pleura. If, however, the angle is like this, suppose the fluid is like this. So this lesion, this angle is actually a acute angle. In such a case, it is actually a collection, loculated collection. And mostly it would be a lesion of the lung rather than of the pleura. It will be a mass lesion or consolidation. Then we have lesions on the X-ray shown like reticulonodular, right? This is cases of pulmonary fibrosis. What do we see here? So here a patient with cardiomegaly and with a pacemaker. We can see horizontal lines. These are actually Curly's B lines, which are present or very prominently seen in patients with cardiac failure. So although the patient may not be too much symptomatic, but if they say they are having breathlessness, especially at night, and if we have just an X-ray, if we see these curly lines, right, curly B line, then they are known as that is pathognomic of pleural effusion. Sorry, of failure. I think this cardiac failure. Okay, this is what do you see here? Very easy. So this is a pneumothorax on the right side. So in a pneumothorax, you will see the whole lung, the part which is occupied by air, to be totally black. The pneumothorax can be big, it can be very small, like this can be the lung and this can be the air, totally black. Okay. Then here you have right upper lobe consolidation with ECG leads. Okay. Right upper lobe collapse, left lower lobe collapse. So here there is a collapse. So earlier we had seen consolidation, here it is a collapse. So if a patient comes with such a shadow, but it is an acute event, then we have to understand that the patient may be having consolidation. But if the X-ray shows, repeated X-ray shows the same lesion, the patient is not having too much of fever, then it is possibly because of old COX or old lesions and the collapse of the right upper lobe of the lobe. Here you can see a shadow going like this. Sorry, and right. So it is a left lower lobe collapse. More prominently, better seen on a CT scan. What do you see here? Is this X-ray normal? So we can see that it is well oriented, well centralized. Exposure is good. The lungs are clear. The clavicles are good. There are no rib fractures. The heart is good. The hilum is good. So what is not good here? So if you see properly, see the diaphragm. So below the diaphragm, there is air. Here, below the diaphragm, there is air. You can see properly here, the air, and you can see the air here. So this is actually pneumoperitoneum. So the patient may come with complaint of breathlessness. You take an X-ray, you see the lung windows, the heart size and everything, and you feel there's nothing. But actually the patient may be feeling breathless, or the patient may be uncomfortable just because of the pneumoperitoneum. In our clinical settings, we have patients coming with vague symptoms કે મને શ્વાસ ચડે છે કે મને થાક લાગે છે કે મને બરાબર નથી લાગતું, है ना? And we take an X-ray as a primary investigation, or as that meme ना, अंदर से कुछ कुछ अच्छा नहीं लगता है, in that Panchayat series. So we take an X-ray, and this is what may turn out to be here on the diaphragm. Okay, what do we see here is a patient of emphysema, right? The lung here is quite more blackish because there is actually the alveolar distension. Okay, and these patients will have a lot of emphysema changes on the CT scan, more prominently seen there. And in such cases, the diaphragm is going to be flattened. This is the true hyperinflation. True hyperinflation is when the diaphragms are flattened. Here we have X-rays which is showing a cervical rib. Can you see this? This is cervical rib, extra ribs, right? Here we have a cavitating lesion, right? So it can be malignancy, it can be tuberculosis, it can be lung abscess, right? From this, it is difficult to say whether it is in the left upper lobe or left lower lobe. I would say it is more likely to be in the left lower lobe. Then we have X-ray here. On the directly we feel that there is nothing much, but if you see properly, I had asked you to see behind the heart. So if you see behind the heart, then there is air fluid level. So this is actually a hiatus hernia. You can see here there is possibly the diaphragmatic hiatus hernia, or the esophagus, the stomach is also herniated upwards. Okay. Now this is very important X-ray because very commonly seen. These are actually miliary shadowing, which can happen in most commonly tuberculosis, but can also happen in occupational lung disease also, pneumoconiosis. Then in patients where you see in ICUs, we are able to see a PA catheter, nasogastric tube like here, going up to here. Then this endotracheal tube is till here. Then a chest tube here. All these tubes you need to see properly, right? These are the ECG leads, okay? So all these things are being seen on the X-ray. What is this? So if you can see dextrocardia, so here you can see that it is written left. So this actually should be the left. This is the right side and this should be the left side. So the heart is actually on this side. So it is a dextrocardia. The X-ray film should have been kept reverse. I think I have. So I think that was the last slide. There was a couple of slides in another slide set. I forgot to keep in them. So Dr. Dhanvi, I think we can open the session for questions. That was the last slide. Sorry for the abrupt end of the slideshow.
Manu sir, for sharing your vast expertise and insights on interpretation of chest X-ray with us today. Your presentation was informative, engaging, and provided valuable learning experiences for all of us. We appreciate the time and effort you took to present this webinar, and we are grateful for your willingness to share your knowledge with our community. We would also like to extend our gratitude to the IAPWAC team for giving us this platform, Vadodara District team for organizing this webinar and bringing us together. Thank you to all the participants for your active engagement and thoughtful questions. You can write the questions in the chat box meanwhile. We hope you find this webinar informative and useful. Finally, I thank you, Dr. Nagraj, and to our technical team for ensuring a smooth and seamless webinar experience. And now we can take the question answer sessions. Sir, can you please mute the participants if they are willing to take the questions?
Yes, ma'am, definitely. Tell them to raise the hand so I can unmute them.
Yes, sir.
If anybody who has the questions, please raise your hand.
And I request all the attendees to turn on their video and share their gratitude for today's webinar.
I think nobody has the questions because I can't see any hands or any text in the chats.
Are they allowed to write in the chat box?
Yes, ma'am. Yes, ma'am. They are able to. Participants can raise your hands.
And I request attendees to turn on your videos, please.
Yeah, Dhruvita Patil. I have given you access to unmute. Please unmute yourself and ask the question. I think she didn't have a question.
So,
yeah, you can move on.
so the question is how to identify over and underexposed X-rays. So nowadays, most of the X-rays are digital, but still in some of the government hospitals, they are either they are still the old type X-rays. So I'll just show you. See, if there is a properly exposed X-ray, then you will be able to see the vertebra up to the manurum sterni. That is it. After that, you should not be able to see the spinal, the vertebra. So that is a properly exposed X-ray. If you are able to see the whole of the vertebra, then it is an overexposed X-ray. If you are not able to see the upper part of the vertebra, then it is a totally underexposed. The second thing is, even in the era of digital X-rays, we are having a lot of problems because most of the chest X-rays are showing the vertebra and everything. Only a few companies or a few centers, they give a X-ray which is really good, like the vertebra is not shown as prominently as in other X-rays. So to show it very briefly, you should be able to see only the vertebra up to the manurum sterni. That is it. And with experience, you'll be able to see which are underexposed and which are overexposed. I hope that answers the question. I think the question was from Shivang Dikshit. Shivang, is it clear? Okay, soft and hard X-ray. I think soft X-ray means soft copy. I think that's it. If that is what you are trying to know. I don't think there's anything soft and hard X-ray. I haven't heard about this. I know for soft copy and hard copy. Okay. So I will ask a question to Dr. Tanvi. Like most of the times you get to see the X-rays of the, like in the orthopedic department, right? And how often do you get to see this, or your students get to see, or physiotherapists see the chest X-rays?
Sir, it is mainly in the civil hospital or SSG hospital setups. Like government hospital, they prefer to see the X-rays mainly in the orthopedic department and in the cardiac department. Wherever they are posted for the ICU settings, they are able to see such cases.
Yeah, so very good. I wanted to hear that only. So the importance of today's talk would be to read the X-ray, especially in the ICU, where you go to give the physiotherapy. In a ICU, the chest X-ray, some of the lesions are very easily missed. Small pneumothorax, small effusion, the misplaced endotracheal tube, a misplaced Rayleigh tube, these are easily missed. So if you know how to see a normal X-ray, and you need to see many normal X-rays to easily differentiate what is normal and abnormal at first instance or at first glance, right? So the more normal X-rays you see and try to differentiate, find out कि भाई ठीक है इसमें कुछ भी नहीं है, it will be easy for you people to actually pick up the abnormalities. For so many years, even we have made mistakes. We have missed a small pneumothorax, right? Or we have missed a small artifact, or sometimes we have overdiagnosed because of an artifact, right? So I think you should know how to interpret this. Second is the orientation and all these things in an ICU. If you are having ICU patient, you are seeing the X-rays, or in some patient the X-rays taken daily or every other day, the orientation may not be proper. So what the chest X-ray, if the patient is lying like this, the machine should focus directly, perpendicular or 90 degree. What happens is a patient is like this and it is short like this. So you have more of an oblique view. And here you may be able to see that the lesions are not seen the way they should be. They don't correlate with the patient's clinical condition also. Okay, of course, you may not be able to point it out to the ICU in charge, but for your information, this is very important. There is a question, how to differentiate between COX and miliary TB. So miliary TB is also COX only. Miliary will be mottling, like millets, right? The millets like jowar, right? So there will be spread all over the chest, the dots. Okay, that is miliary tuberculosis. And otherwise, tuberculosis, it is either cavity lesion or a consolidation. So in Cox, usually you will have sputum. In miliary TB, you may not have sputum. It may be more of dry cough. And in such a case, a CT scan followed by bronchoscopy is to be done. Other question is by Freya, how to reveal middle lobe and lower lobe lesion. So as I said, if it is a right middle lobe lesion, then it will be in continuation with the right right border of the heart. So if there is a lesion in the lower zone, and if the right border of the heart is not seen, then it is usually middle lobe lesion, middle lobe consolidation. If the border is seen, then it is most likely to be unless it is a lower lobe lesion only. The second thing is you can take a lateral X-ray, but I think nowadays CT scan is very not so costly. There are some trust hospitals where you can get CT scan even for 1,000 rupees, which is just double of X-ray in the private. Any other question? So my advice would be, again, see as many chest X-rays, normal X-rays as possible, and try to find out if there is any abnormality which you can detect, or even amongst the normal X-rays, you may be able to see the soft tissues, the heart shadow, rotation. You can start with seeing whether the X-rays are properly oriented, properly rotated, and properly exposed or not. At least these things you start seeing even in a normal X-ray. And I'm sure it is going to help you in finding out abnormalities in other X-rays. Yeah, Krishna Bhimani has some question. You can either type or you can unmute yourself, Krishna. Krishna, you can unmute yourself. I think you'll have to type. Yeah, just a second.
Krishna, can you type in the chat box?
Collapse and consolidation. Okay. So the question is, how to do collapse and consolidation on chest? So it is difficult to really differentiate between collapse and consolidation, especially if the fissure or the border of the lesion is convex. So normally in a consolidation, patient having consolidation, that is pneumonia, unless put otherwise, the patient will be having an acute presentation with high-grade fever, short history of cough, breathlessness. If it is a collapse, then patient may have fever because of the infection, but the patient may not be so breathless. So if you see the X-rays of old TB patients, there will be a lot of lesions, right? The whole lung may be involved, but still they will never be breathless. On the contrary, if you see a small pneumonia, the patient will be breathless, tachypneic, tachycardia, right? SpO2 will be low, and they will have a short history. So this is a very rough way of, this is the way I would differentiate between collapse and consolidation. Second is on collapse, we have to see in the collapse, the air bronchogram will not be so well, and there will be actually bronchiectatic changes. In a consolidation, there will be very good air bronchogram. Dhruv has some question. Dhruvita. Okay, the affected lungs are more visible in lateral view than AP view. Then why it's not been done now? It's a very good question. Actually, now CT scan availability is very easy. Earlier, we didn't have CT scans so well, so readily available. The patient's affordability was a problem. Rather than getting two X-rays like AP and lateral, now we can have more information with the HRCT chest. So that is why most of the time lateral lateral views are not taken, right? Only in an institute where, as I said, in an ICU setup, where the patient cannot be shifted, I would ask for a lateral X-ray. What possible misinterpretation can there be if the X-ray has rotation? Okay. So if the patient's X-ray is rotated, one is you may actually miss the shadows on the hilum. Then you can miss shadows or small consolations like in the lingula or in the right middle lobe. So suppose, for example, if there is small lesion in the right middle lobe and the lung is rotated, so the lesion will actually be overshadowed by the heart shadow, and though you may miss it. Then you can miss small effusions also. So Rajvi has asked, so which is more preferable, chest X-ray or CT, chest CT? So chest X-ray is always preferable because it is less cost, it is cheaper, and it is the first line of investigation to be done in any case. If you are not able to find any lesion and you suspect something more, then you should go for a HRCT chest. If it is an old patient and you already have a chest X-ray done a few weeks back or a few days back, then you can go directly for a CT chest. CT chest normally would cost anywhere from 4,000 to 5,000. Only in trust hospitals, it is around 1,000 to 1,500. Chest X-ray is costing 300 to 500 rupees in Baroda. In trust hospital, it is from 100 to 150 rupees. So as you can see that you cannot ask every patient to undergo CT chest. And of course, a CT chest would have more radiation than a simple plain chest X-ray. We have a very interested and intelligent audience here. They're asking very good questions. Krishna has a question.
Krishna, please unmute yourself. I have given you access to unmute.
Or better, you can type it so for everybody to see. That will be faster. Just type in the chat box. Anyone else has any questions? Please write in the chat box. Okay. How many chest X-ray exams are safe? So in a year, I think if it's not required, not more than 3-4 X-rays should be done ideally. But if required, we can have 4, 5, 10, whatever. But strictly, we have to do as less as possible. In an ICU, where the patient's life is staying, we cannot think of the long-term effects of many X-rays. So there, I think we can be liberal in taking X-rays. Of course, whenever we take an X-ray, there should be a rationale behind it. Just because available hai machine, patient is paying, and we don't want to use our clinical judgment, does not mean that we should do X-ray now and then. Can chest X-ray show cyst? Yes, they can show cyst. There's one question, I think it was, no, it cannot show blocked arteries. Chest X-ray cannot show blocked arteries. For that, you need to have a CT with contrast. On chest X-ray, you can have a hydrated cyst, which is going to be very homogeneous with a smooth border.
We have questions now. I think participants don't have questions, sir. So we can end up the session over here. Myself, Dr. Tanvi, being the Vadodara District Sub-Coordinator of IIP Women's Cell, we express our gratitude from our team member, Dr. Pragna Langle, who is Vadodara District Coordinator, and Dr. Joel Tejpal, who is Vadodara District Sub-Coordinator. And we look forward to our next learning opportunity together. Thank you so much, sir, for your presence.
Okay, thank you everybody for giving me an opportunity to talk. Thank you.
Here we end the session. Goodbye and stay safe.